Thanks everybody for joining us. This is our July event for NASGP's clinical webinar series, and I'm here with Dr. Eloise Elphinstone. We're going to have a talk for about 30 minutes. Then we'll have about 5 or 10 minutes for questions afterwards. Feel free to ask questions as we go along using the chat, or wait until the end and you're able to ask them either in the chat or directly when we get to the end of the talk. I'm handing over to you, Dr. Elphinstone.
Thank you. So thanks very much for having me again. I was here earlier in the year talking about ovarian cancer, but today I've been asked to talk about menopause. And so what I'm going to do, obviously it's a huge topic, but I thought I'd focus on some updates. We've got some new guidance from the British Menopause Society, so go through that. Hopefully it's not going to be too dry, but so I'm going to end with some scenarios just to try and put it into sort of practice a little bit more. So some about the updates, but also just some scenarios that I've come across that I thought might be quite helpful. So it's not letting me go forward. There we go. So just a little bit about me. I'm a GP, but I've got the Advanced Menopause Certificate with the British Menopause Society. I trained at West Middlesex Hospital doing my menopause work, and I now do a clinic there, linked with Chelsea and Westminster, and we have NDTs together as well. I also work in a private menopause clinic called Menopause Care. So I end up sort of half my time doing GP and half my time doing menopause clinics, and I've worked with the Primary Planning Association as well, writing leaflets on postnatal health, but also menopause for them as well. So today, what I thought I would go focus on is there's a new guidance on bleeding on HRT, and I think this has become quite a big topic, which is why the British Menopause Society have done this guidance, because bleeding is not necessarily uncommon on HRT, but often people ended up getting referred on to 2-week waits. The clinics in the 2-week waits are pretty overwhelmed, and actually most of the cases there's nothing sinister going on. So these new guidance have been brought out just to try and make it a little bit more simple to know who to refer onwards and who not to, and what to do with bleeding. It's 47 pages, it's quite long, so what I thought I would do is try and summarise it just to make it sort of more practical and the useful, sort of pick out the useful bits as well. And then I thought I'd end, so I'd focus on that and then end with some case studies, one which is bleeding on HRT, but then some others which are patients I've seen, which is not uncommon, but sometimes difficult to deal with, and just to give some tips about how to deal with it in GP before needing to refer on, because I know lots of the menopause clinics are quite overwhelmed where I work. There's a 4 or 5 month wait. So hopefully this will help a little bit with some of these more dilemmas as well. So these are the new guidance. The British Menopause Society have released them. It's management of unscheduled bleeding on HRT. As I say, it's 47 pages. It's quite wordy, but there are some really useful bits. So it is useful having a quick look at it, but I've picked out the most salient points really. And what they've divided it into is how to approach a situation where somebody comes and they are bleeding and what to do about it. So they've suggested dividing it into, or they've divided their guidance into how to assess the bleeding, when to investigate this bleeding, how to investigate it, so what to do, and then how to adjust HRT to try and minimise the bleeding if nothing else is causing it. So what unscheduled bleeding is really is any unusual bleeding on HRT. So obviously if you're on sequential HRT, you could well continue to get periods, but they can be erratic. So you can sometimes get periods or not get periods. And it's not talking about that so much. It's talking about people who are getting bleeding throughout the month, or are post-menopausal and then start bleeding, or getting heavier bleeding. And it's what to do in these situations. So with unscheduled bleeding, I think what the guidance suggests, which I'm sure we would all probably do, is to sort of work out exactly what's going on. So take a good history of what the bleeding actually is, what the sort of pattern of the bleeding is. And as I mentioned, is it that somebody is now bleeding every day since starting? Is it that they haven't bled, they're postmenopausal and they've started bleeding? Or is it that it's actually normal periods, but it's much heavier? Then finding out what HRT they're on, because again, it does vary. So are they on sequential or are they on continuous? So on sequential, you are likely to get either a withdrawal bleed after coming off the progesterone, or it's not always in sync with what your body's naturally doing. So you might get periods in between cycles that's not really when you're stopping progesterone, but is still a natural period. Or obviously with continuous, the idea is not to be bleeding at all. But also, are they on patches? Are they on gels or sprays? What progesterone are they on? Because that can affect the bleeding pattern. Or are they on oral? Because we find that with certain HRTs, you're more likely to bleed, and sometimes just switching the type of HRT or switching the progesterone can be helpful. And then this is the big bit that they've added in with this unscheduled bleeding, is looking at the risk factors. And I'll go through this on the next slide. But ultimately, it's these risk factors which will determine who to refer onwards, when to refer onwards, and what to do, whether it be an ultrasound or whether it be a 2-week wait, or whether it be waiting and tweaking things a little bit. So this is, again, trying in a 10-minute quick appointment to try and work out which are the higher risk people who are bleeding, and which are the people where it is very low risk and it's much more likely to be the HRT. And the other thing then that's also recommended, and again, this is obviously all time linked, but to do an examination. So with bleeding, on HRT, the jump is it the HRT, but actually it's also worth thinking, has swabs been done? Is there any signs of infection? Are smears up to date? Obviously you can't do a smear if they're bleeding, but checking that they're up to date. A BMI is really relevant, and that links in with the risk factors. And also where the examination can be really helpful is to look for things like vaginal atrophy or genitourinary syndrome of the menopause, because that can link to bleeding as well. So people can go through a whole lot of investigations, and actually it's really localized bleeding, and that can be treated quite easily with vaginal estrogens often. So the risk factors. So this is the sort of big bit which is, you don't need to necessarily know off by heart, but it's worth just having at the back of the mind of people who are higher risk and you should have a lower threshold of referring onwards. And they're divided into major risk factors and minor risk factors. So with the major risk factors, so weight is a big risk factor for endometrial cancer. So if somebody's got a BMI of over 40, that would be classed as a major risk factor. There's also couple of genetic conditions that increase the risk of endometrial cancer. So Lynch syndrome, which is hereditary non-polyposis colorectal cancer, does increase the risk of endometrial cancer quite substantially. So if anybody has that and there's any bleeding, that would be classed as a major risk factor, and you'd want to take that seriously. Estrogen only HRT for more than 6 months. So obviously with HRT, if you've got a womb, you should be on estrogen and progesterone to be protecting the womb lining. But there are some situations where it's been prescribed wrongly, or the patient hasn't taken the progesterone, the patient is intolerant, they feel awful on it, they stop taking it. So if they have been on estrogen only for more than 6 months, that would be classed as a major risk factor. Tricycling HRT. So this is what is sometimes done with people who are progesterone sensitive, where they only have progesterone once every 3 months. So that would be classed as low dose, low dose progesterone, which would increase the risk of hyperplasia and therefore endometrial cancer. So if they've been on that regime for more than 12 months, that would be classed as a major risk factor. And then linked in with that, low dose progesterone. So again, some people who are progesterone sensitive, their progesterone levels are doses are reduced to try and minimize the side effects, but that would increase your risk of hyperplasia. So if you've been on, if somebody's been on that for more than 12 months, that would be classed as a major risk factor. And then the last thing, which is also quite relevant and really important for us to remember, is that somebody shouldn't be on sequential HRT for more than 5 years. So if they've started it over the age of 45, 5 years should be the top length of time. Even if they are still getting periods, at that point they should be changed over to continuous. So if it is more than 5 years, that would be classed as a major risk factor. The minor risk factors are similar, but where things have been done for shorter periods of time. So BMI of 30 to 39, unopposed estrogen, so estrogen only for 3 months, for more than 3 months, but less than 6 months. The tricycling, so once every 3 months, that's between 6 and 12 months. Being on low dose progesterone for 6 to 12 months. Where the progesterone is not proportionate to the estrogen, and this is another thing that I'll pick up later. This is new with this guidance. So if somebody is on high dose estrogen and their progesterone hasn't been increased accordingly, if that's been for more than 12 months, that would be classed as a minor risk factor. And then a couple of other things, anovulatory cycles. So in PCOS, it's not unusual to not ovulate. If you ovulate, you then get left with the corpus luteum, which is producing progesterone, which is therefore protective to the womb lining against the estrogen. So people who don't ovulate, even if they're not on HRT, they are higher risk of endometrial cancer because of the unopposed estrogen. And diabetes is another risk factor. So I'll go back to these about referring onwards, but these are the risk factors that the guidance talk about. So if you've done your history, because somebody's come with this unscheduled bleeding, you understand what's going on, you know about the risk factors. When do you then want to start investigating this bleeding? So the guidance does try and make it a bit clearer. So ultimately, if you have just started HRT, it is not unusual, whether that be continuous or sequential, to bleed in the first 6 months of starting. So if there's any bleeding in the first 6 months, that you don't need to necessarily refer onwards if there are no risk factors, unless obviously it's something that's really very unusual that you are worried about. But bleeding on first starting is not unusual. You might want to be tweaking in that time, in that 6 months, but within 6 months, you don't need to refer. Post 6 months of starting HRT, you would want to be referring onwards for an urgent ultrasound scan if there are no risk factors. So not straight to a 2-week wait, they're saying. Now, this again is dependent on area and dependent on department if they're up to date with the guidance. I know where I work locally, I've tried to do this and it's been rejected and it's straight to 2-week wait. But ultimately, what we're trying to reduce the 2-week wait referrals. So I think if the departments are keeping up to date, that this is the new guidance. An urgent ultrasound means within 6 weeks. If somebody's been on HRT but it's been changed, so that means the dose has been changed or the route of giving it, gone from patches to gels or any changes, within 3 months of the change, it's not unusual to get bleeding. So that is acceptable. But again, if there's bleeding that continues after 3 months of the change or starts after 3 months of the change and there's none of those risk factors, then again, it would be a referral for an urgent ultrasound scan. If, however, you've got unscheduled bleeding or bleeding that's prolonged and there's 2 minor risk factors, so the bottom of the list ones, then you don't wait for this 6 months or 3 months that I've talked about. You would be offering immediately an urgent ultrasound within 6 weeks, so irrespective of when they started it. If there's 1 major or 3 minor risk factors, then consider a 2-week wait referral, again, irrespective of when they started. Again, it's a bit of a difficult one. I mean, with the BMI factor, that would mean that they would be automatically referred straight on. So I think it's sort of working out what would seem reasonable, but ultimately that's trying to simplify the guidance. And as I mentioned above, in that time, if you're waiting, if it's in that 6 months of starting or 3 months of changing, you can tweak things in that time to see if you can stop the bleeding, which obviously would hopefully mean you wouldn't have to be referring onwards. But now, obviously, if we're doing if we're requesting the ultrasounds, then what do we do with the results? Obviously, if you do a 2-week wait, they will do the ultrasound and they'll do biopsies and things, and so we don't need to worry about it. But if we're organising the ultrasound and it's happening, we need to know what to do with the results. And again, that's tried to be simplified. I think in the perimenopause, it's not quite as black and white as it's explained, but ultimately what the guidance is saying is, firstly, really try and do the ultrasound scan, if possible, after a period, because that is going to be when the womb lining's at its thinnest. If you're doing it just before a period, it's going to come out as thick and then ending up needing to investigate further. So if the ultrasound can be done after a period, and if you're perimenopausal, anything less than 7 millimeters is thought as normal. And then you don't need to refer at that point. If it's more than 7 millimeters, you'd be wanting to refer for a 2-week wait. In postmenopause, it's a little bit simpler because you're not getting the changes in thickness, and anything less than 4 millimeters is normal. Over 4 millimeters, you'd be wanting to refer for a 2-week wait. However, if that's not comes back normal, so at that point you could do tweaking of the HRT, which I'll talk about. But if you've done tweaking and the bleeding continues for more than 6 months after those adjustments, then you would automatically refer for a 2-week wait at that point. You wouldn't want to get another ultrasound, even if the original one was normal. If you have referred onwards for a 2-week wait because the ultrasound shows a thickened wound lining, normally what they'll do is they'll investigate and often do a papille biopsy. So that's a blind biopsy. They can't see where they're taking it from. If it's a good biopsy, which they'll often report that if it's a good sample and it's normal, then again, you'd want to be tweaking the HRT and you can be reassured for 3 months. But if the bleeding, despite tweaking the HRT, if the bleeding continues for 3 months after the papille biopsy, then you'd be referring back for gold standard hysteroscopy, which is where they can see and take a biopsy of any areas they're worried about. If you've had a hysteroscopy, then that provides reassurance for 6 months. But again, if you've got continuous bleeding at that point or bleeding that starts again post the 6 months, then the story starts again about whether you need to refer onwards or refer back to gynecology. So hopefully, I know this is all a bit dry and hopefully not too complicated, but hopefully if you now know what you're doing from a referral point of view, but therefore you've either referred onwards, everything's normal and you want to adjust the HRT, or you're not ready to refer, but people are bleeding and you want to adjust the HRT, there's actually quite a few options of what you can do to try and help. And ultimately, the majority of people, I've got a quote later, but the majority of people who are on HRT, who are bleeding, it's because of the HRT. It's much less likely to be anything sinister. So it's looking at the HRT to then decide why are they bleeding and what can you do about it. And so the way I think about it is estrogen thickens the wound lining and progesterone keeps it thin. So we want to be looking at the proportions of estrogen and progesterone. Is estrogen too high? Is progesterone too low? Can we change the estrogen to a different type, or can we change the progesterone? The first thing I think it's worth asking about is how are people taking the HRT as it's being prescribed? So I think now that we're going more and more to these transdermal options, a pill is quite easy and it comes in a pack and you follow the pack. Whereas now that we're doing even the combined patches, the sequential patches, it comes in a box with the estrogen only ones first and then the estrogen progesterone. But people don't always realise that and just pick out random ones for the box. So you're not always doing it in the right order. So it's always worth asking, what are they doing? Are they taking their patches in the right order? Are they remembering to take their progesterone? Because again, if you're splitting estrogen and progesterone and you've got to take your pills at night and you forget, that's not unusual to cause bleeding. And are they taking it as prescribed? So that's really important. And if not, it's really worth just tweaking that or trying to find a regime that's actually much easier for them to take if they're struggling doing what has been prescribed. Then looking at the dose of estrogen and the dose of progesterone. So estrogen-wise, that is what's thickening the wound lining. Ultimately, obviously, the reason you're on the estrogen is to try and help your symptoms. But if somebody's on higher dose estrogen, their symptoms are really well controlled, but they're getting the bleeding, then actually it might be worth trying to bring down the estrogen just to see if that helps control the bleeding a little bit better. Obviously, that's harder if the symptoms are still there or the symptoms come back on reducing. And then it's worth looking at the progesterone. So the progesterone is what keeps the wound lining thin. Ultragestan is what we use a lot. It's not the best at stopping bleeding. It's perfectly good enough to control the endometrial thickness, but you can get breakthrough bleeding. So options are going up on the dose of progesterone. So for example, if you're on continuous Ultragestan, taking 1 tablet every night, you can go up to 2 tablets every night. Or if you're on the sequential taking 2 tablets, you can go up to 3 tablets. So that's often quite a good option. other than if people are progesterone sensitive, which makes it much harder, because obviously you don't want to give something that gives them side effects, but then you want to control the bleeding. So if the Ultrasound just isn't controlling bleeding, it's worth thinking about other progesterones. So in some people, so medroxyprogesterone or norethisterone, not as body identical. So for progesterone sensitive people, often they do have more side effects with these, but they're quite good at controlling bleeding. Patches are probably one of the least good at controlling bleeding. People often get breakthrough bleeding. So if they're on a combined patch or sequential patch, then maybe it's worth trying a different option, going to the Ultrasound and a different option to see if that controls things better. Pills as well are often better at bleeding profile than any of the transdermal options. They're also really easy to take. And at the conference, the British Menopause Society conference last year, the whole talk was about oral versus transdermal. Should we only be given transdermal, or should we be considering oral? And ultimately, the conclusion at the end is, I think the pendulum switched so much to the other way of giving transdermal because of the slight increased risk of blood clots with the oral. But actually, we mustn't forget the oral options. They are good. They work well. People absorb them well. People often don't get bleeding so much with them. So it's good options as long as there's not the risk factors that you can't take them. I tend to say if you do use oral, there are some ones with the nicer progesterones. The progesterones are often the one that people get side effects from. So Femiston, for example, it's got digesterone in. It's one of the nicer progesterones. So that's often my first line one to go with. Or there is a relatively newer one, Bijuve, which is oral estrogen with Utrogestan. So again, that can be a good option for some people. So it's not worth forgetting that as an option. And then my often go-to for bleeding is the coil, the Mirena option. It's brilliant in majority of people at controlling bleeding. It gives nice continuous progesterone. It's localized to the womb lining, so it beautifully protects the womb lining. And we think at whatever dose of estrogen at the moment, we don't have the studies about it, but on higher dose estrogen, we think the Mirena in itself is okay. So that is a really good option if the patient is willing to give that a go. And then obviously you can give whatever estrogen works alongside that. Linking into what I said earlier about vaginal atrophy, that it's important not to forget that, because that can cause bleeding, and we are tweaking everything else, and it's actually much more locally that's bleeding because the area is just dry and cracked and sore. So it's really worth considering vaginal estrogens just to manage vaginal atrophy if need be. I've put this at the end, consider stopping HRT. Actually, the guidance have it at the beginning, but you don't want to be stopping HRT if it's really helping symptoms. So I wouldn't jump to that as the first option if somebody's symptoms are well controlled but they're bleeding. However, there are some people that we really struggle with the bleeding. All these things have been tweaked and changed, and actually they've got to the point they can't remember why they were on the HRT, and actually the bleeding is such a stress. So sometimes considering weaning down or weaning off can be helpful. You can see if the bleeding stops, but it also can just give a bit of a chance to sort of rethink. And I do this with other things as well. If we're not controlling symptoms well enough, or people are really intolerant and getting side effects, sometimes weaning off, starting again can be helpful just to work out where you're at, because there's been so many changes. And I've picked these couple of charts out from the guidance to try and help with the bit that I mentioned earlier about dosing of progesterone depending on dosing of estrogen. So they put a chart here. It's quite an interesting chart because it's different to some of their previous ones, and some of it isn't quite what I had necessarily originally thought. I mean, the Lenzetto spray is an interesting one. They're classing high dose as 6 sprays, way above licensed dose. But what it shows is what they're classing as ultra low dose, standard, moderate, or high, and then comparing the different products. So again, if we're switching from one to the other, it helps knowing what we're switching to get equivalent dosing. But the reason they've put this in is then because of this next chart of looking at dosing of progesterone depending on dosing of estrogen. So if people are on the ultra low, standard or moderate dose, generally the dose of progesterone is as we know, the 100 milligrams at night every night if we're using Ultragestan for continuous, or the 200 milligrams of Ultragestan sequentially. And that is still recommended unless you start getting bleeding on any of those. And people who absorb differently can get bleeding on low, medium doses. So that's the point that you'd want to then consider going up on the progesterone. However, if somebody is on high dose estrogen, so that would be the 100 microgram patch, the 4 pumps of estrogel, they're saying the 6 pumps of Lenzetto. And the other thing they're saying, I think they're going up to 4 milligrams of oral estrogen, which is really high as their high dose. But you would be automatically wanting to increase the progesterone if they're on these high doses, as long as they can tolerate it. And again, it's very individual. I wouldn't say this is a blanket. If you've got somebody who's progesterone intolerant, you really want to be discussing pros and cons. But the thought is, if we're thickening the womb lining with the estrogen, we want to counteract that with the progesterone. So that's quite useful just to give a sort of baseline guidance. Again, there's the other options of progesterone there, and then there's the coil, which is always a really, really nice option of whatever dose of estrogen. So I'm just looking at timing. I have got now a couple of case studies just to hopefully put this all a bit more into sort of perspective. These are all patients that I've seen. And this first one is linking in with bleeding, just to sort of try and put everything else into reality. So this was a 46-year-old lady that I saw whose period stopped at 52. So she is clearly postmenopausal. She is on 4 pumps of estrogel daily, and she takes 100 milligrams of Ultragestan at night, every night. She's been on HRT for the last 2 years, but recently increased to 4 pumps of estrogel daily. But she started intermittently spotting bleeding for the last couple of weeks. So this I mentioned slightly earlier, but I think this is really helpful to see that this is the British Menopause Society who put out a statement basically saying that the risks of endometrial cancer in women with unscheduled bleeding on HRT is significantly lower than with postmenopausal bleeding in women not on HRT. So if somebody's bleeding, they're not on HRT, that's much more likely to be something more sinister and referring on for a 2-week wait than somebody's on HRT, because it's likely the HRT that's causing it. And therefore, modifying the progesterone, or as I said, the estrogen, can be the answer in these situations. So if somebody presents like that, as the guidance was saying, you want to take a really good history. You want to make sure that they're up to date with their smear test. You want to make sure that they're taking their hormones as prescribed. You want to consider doing an examination. And then in her specifically, I'm going to go back to this. We've got a couple of factors here to think about. So the first thing is she's recently been put up on her dose. So if recent means within the last 3 years that you'd want to clarify, then as per the guidance, that change could in itself cause some bleeding, which is likely to settle. So again, if it's in the 3 months, you can decide what you want to do, but potentially adjust things in that 3 months before needing to refer onwards. The other thing is that she's been increased to 4 pumps daily of the gel, but the progesterone dose hasn't changed. So if we're looking at that previous chart, that would be classed as high dose estrogen. So actually, probably automatically, I would increase the Ultragestan at the same time as I'm increasing the estrogen. So being on 200 milligrams every night. But because that hasn't happened in this situation, I think that would be perfectly reasonable to not need to refer onwards, but actually then increase up the Ultragestan to 200 milligrams and give that a little bit of a chance to settle to see if the bleeding stops. To also question whether she needs that high dose of estrogen. Why has she gone up? Has it made a difference? If it's not made a huge amount of difference from a symptom point of view, then maybe actually you want to go back down to 3 pumps. And obviously, if we've changed all of these and yet the bleeding continues, that's when you'd want to think about after 3 months referring on for an urgent ultrasound. But also maybe in that time think, well, maybe we want to change to an alternative option, try a patch, or maybe consider the Mirena coil. When I mention patches, obviously people do also bleed on those, and equivalent dosing would be you couldn't do that with a combined patch to get the equivalent dosing. So you'd be wanting to do, say, 100 microgram patch with maybe a Mirena coil as an alternative. But basically, there's lots of options of switching round. But I think there's an easy thing here to do first. First, you give it a little bit of chance to settle, and secondly, increase that progesterone. So moving away from bleeding, but from other sort of common issues that some people have with HRT. This was another lady that I've seen recently. So she's a 46-year-old who had viral meningitis at the age of 40, was really struggling from post-viral syndrome after this. But then more recently has got sort of new symptoms that have developed and which has led to real difficulties at work and wanting to potentially consider changing work or stopping altogether. The symptoms that she described were hot flushes, mood changes, and real anxiety linked with work. So 6 months previously, she had started HRT because the doctor felt that although she had the post-viral syndrome, these were new symptoms linked in, and it was likely to be perimenopause symptoms on top of that. So she was started on estrogel 2 pumps daily, which is the classic starting dose, with Ultrasound for the 12 days of the month. She felt really amazing on the estrogen. Very, very quickly, she felt better. That's what she initially was started on. But as soon as the progesterone was added in, she started feeling awful again. Her anxiety came back, her mood was low, she was feeling bloated, and she was feeling back to square one. So she came to see me to have a think about, well, what do we do? Because she felt so good on the estrogen, but so awful on the progesterone. And this is a sort of pretty classic situation of what I would call progesterone intolerance. More common in people who have had PMS in the past. PMS is because your progesterone level goes up pre your period, and and the estrogen level comes down, and it's that reaction to the progesterone. As soon as you have your period, the progesterone goes back down, and the symptoms clear. So PMS is classically before your period. If the symptoms continue on through the period, that's more perimenopause. And they can be both, PMS symptoms can be both psychological and physical symptoms as well. But progesterone intolerance mimics it. So when you take the progesterone, you're clearly giving the hormone that people can be sensitive to. Even if they've never had PMS in the past, sometimes people are sensitive to progesterone. It's more common if they have PMS. So one question that I always ask these patients is, have they been on contraception in the past? And if so, what? And did they get on with it? Because there are some people who've been on multiple different types, and all different types cause side effects. And it's much harder in those situations because clearly they're sensitive to all different types of progesterone. However, if somebody's been on contraception in the past and actually they've been on one and it's not been too bad, then maybe it's just certain progesterones that they're sensitive to. Ultragestand is a micronized progesterone. It's very similar to our body's natural progesterone. So often people have less side effects with that, but that's not always the case. Some people are fine with others and not Ultragestand. So it's really interesting getting a bit of a background. So if in whatever situation, you obviously need to be giving the progesterone if they've got a wound. So it's trying to find ways around it. So one option in this situation would be continuing with the Ultrasound, but considering using it vaginally. Now, vaginal administration of progesterone is off license. It's used in IVF, so we know that it can be done. We know that it gets absorbed, but it's not been licensed in HRT to be used this way. But obviously, the point of the progesterone is to keep the womb lining nice and thin. Giving it vaginal is giving it nice and localized to that area. So the thought is it works quite well with minimizing the systemic absorption, which hopefully minimizes some of those side effects. So it's advocated by the British Menopause Society for progesterone-sensitive patients, as long as it's explaining that this is an off-license usage, so we don't have studies to see how well it's absorbed. But in some people who are desperately really need the HRT, but obviously cannot tolerate the progesterone, this is potentially a way around it. You can use exactly the same oral tablets, but use them vaginally. The capsule, the sort of gelatin capsule, doesn't always get absorbed. So people do get a bit of a sticky mess in the morning. But as long as it's not a whole tablet that's coming out, it's been the central bit's been absorbed. So that is an option. The other option is there are pessaries. So these are the pessaries that are used in IVF. So there's Lutagest, which is the 100 milligram pessary, although stock-wise at the moment, it's really hard to get hold of it at all. And then there's 200 milligram pessaries, which are the Ultrasound pessaries or the Cyclogest. And some people find they're still quite sticky, but they can be more tolerated. They are more expensive. So sometimes it's people it's not wanting to be prescribed on the NHS, but that could be an option. And I do find patients sometimes are more tolerant to those than even vaginal oral estrogen. So as in the oral tablet that you use vaginally. So that is one option, and that's often an option that I would start with trialing just for a 3-month trial to see if that helps. And what I would also say is often initially people can get these side effects, but if they persevere, it often does get better if they can tolerate it, to persevere. So to try, if possible, to give it a bit more time, to tweak it to vaginally and give that a bit more time. Or consider an alternative option. And the Mirena is a good option. A lot of people, particularly progesterone sensitive patients, are nervous because in their mind they think they're sensitive to all progesterones. And sometimes they are, but actually the Mirena can be a really good option because it works really localized to the womb lining. Therefore, less of it gets absorbed systemically, which hopefully minimizes those side effects. And it's a brilliant way of protecting the womb lining. Occasionally, we do go low dose, so lower than the licensed dose of progesterone, which, again, cautiously done because of the endometrial thickness and bleeding. And if people are below the licensed dose, then I'd recommend getting an ultrasound every 6 to 12 months to make sure the womb lining is staying thin. But in some people, there's no other option, and they really need the HRT. And then again, from a coil point of view, so the Mirena is licensed. There are lower dose options like the Kyleena, which is not licensed, but there are some cases where, certainly in the more complex clinics, people are given them, but they are monitored. It might be these are the situations, if you're thinking about low dose progesterone or Kyleenas, that actually you want to refer into the menopause clinic because it's off license for them to sort of take over. But the point of me saying this is there are these options, and it's worth making sure that people are referred in if need be, so they can get the HRT that they need. Because often these people, the PMS type patients, they've struggled for years with their hormones, and then it gets worse in the perimenopause as well. So it's really important to try and optimize it. I've just thrown this slide up as well. This is from some other British Menopause Society guidance of different progesterones. The one that's not here, that's new, that is quite an interesting new option it's called Slind. It's drospirenone, which is the progesterone that's in Yasmin. So often people get on well with Yasmin when they're younger because it's a nice progesterone. We've never had it as a progesterone-only pill until now. So it's licensed for contraception. It's useful for PMS patients. I've just recently prescribed it the first time for contraception for a PMS patient, but to see if it stabilizes hormones. It's off license to be used for HRT, and I wouldn't necessarily recommend at the moment using that. But again, menopause specialists might have that as an option. So again, we're getting more potential options, which hopefully cause less side effects for these sensitive patients. And whizzing through, and keep an eye on time. This is the last case study. But just to quickly throw this in as well. So it's a patient who I saw who had premature ovarian insufficiency. So she went through the menopause, had blood tests done showing raised FSH when she was 38. She was started on HRT, which is what I'd recommend irrespective of symptoms. I'd definitely put somebody on HRT if they were POI, and I would be referring these to a menopause clinic and carrying it on until the age of natural menopause, at least, so 50 or so. She is on 4 pumps of estrogel, 100 milligrams of Progesterone, and clonidine has recently been added in because her symptoms are creeping back. She feels tired all the time. She's aching with running. She feels hot, anxious, poor sleep, reduced libido. So she came to me at this point saying, what do I do? I'm top dose of estrogen. Clonidine's been added, but it's not helping the hot flushes. So options here. I mean, it's a difficult one. She is on top license dose, but she went through the menopause really early. And I do find that sometimes people who have POI sometimes do need higher doses of estrogen. You want to check she's absorbing it. Clearly, she's been on it for years and it's worked, so she likely is absorbing it. And although I wouldn't normally recommend bloods routinely to monitor estrogen levels, this is sometimes the point where it is quite useful. She's postmenopausal. She's not going to be getting fluctuations, which makes bloods difficult to interpret. She's on top license dose. So getting a blood test to see what the estrogen level is can be interesting to see, well, is she on enough? Do we need to think about going above license dose? Is she absorbing it? Or is she not absorbing it quite as well now? Do we want to be considering changing to something else? And generally, and there is not real sort of guidance on this, but if the levels are between 300 and 600, that's when we find people get the majority of benefits. So that's one thought. So do we need to change estrogen? Do we need to go up? What about testosterone? So if estrogen levels are actually quite good, we could think about testosterone. It's not going to help all of her symptoms. So to me, I think that it feels like the estrogen's probably not quite right for her. But testosterone would be another option to think about. And this is when we've optimized the estrogen as much as we can. Just going to my testosterone slide. So it's off license, but in some people, and not everybody, I tend to say it works in about a third of people, and it makes not a huge amount of difference in about 2/3 of people. But it can be useful. The study suggests it's useful for libido in these people, but anecdotally, and this isn't necessarily a reason to start, but I do find patients find brain function and energy levels, then it can be really, really helpful. So you start with a blood test prior to starting. You look at the total testosterone, making sure it's in female range. You then review at 3 months with a further blood test at that point. And I'd recommend not using the testosterone on the morning of or the night before the blood test. And you give a 3 to 6 month trial to see if it works. If it doesn't make any difference, I just stop it at that point. If it helps, clearly that is the added benefit. And I find people with POI or who've had surgical menopause, often other people do benefit more from the testosterone. So it's worth a thought. And the one I tend to prescribe, because lots are out of stock, is the Testogel on the NHS. There's Androfen, which is the one from Australia, but that's only available privately. I've just skipped a bit because I know we're running out of time. I mean, the only other bit here is because I was talking about above licensed estrogen. There was this sort of statement by the British Menopause Society, because I think there's been some people on really very high doses of estrogen. Ultimately, we should be trying to stay in licensed dose of products, but obviously it does depend on absorption from patients. So ideally stay in licensed dose, switch to different estrogens if need be, but in exceptional circumstances where people aren't absorbing brilliantly, then occasionally you do want to go high, but you want to make sure that the progesterone should be increased proportionately as well, as I was discussing previously. So to summarize, ultimately, my main tips are go back to basics. Why is the side effect happening? So why are they bleeding? Is it the estrogen's too high, the progesterone's too low? Why are they getting side effects? Is it linked with when they're on the progesterone? Are they sensitive to progesterone? Tweaking, as I suggested, but sometimes weaning down or weaning off, starting again, refreshing and starting from scratch. But in all these situations, they're quite complex, some of these. So if you're struggling, do refer onwards to the menopause clinics, because there's often options that we can do or have a bit more leeway to go off license sometimes to try and help these patients. And that is it. Sorry, I feel that's a real whiz through, and I hope I haven't confused things more, but hopefully there are some nuggets of useful information there.
Great, thank you. Yeah, and the great thing about the video is people can watch it back if there's anything that they were confused about that comes up later. We are on 2:45, but I think we've got time for 1 or 2 questions if there's anything pressing. So you can pop it in the chat or just turn your mic off and ask it straight. Anything about testosterone? Because I don't think we have covered that in past talks on HRT. That's a really interesting slide.
Sorry, I whizzed through that, and I'd love to spend more time on testosterone because it is useful in some people, I would say, but not everybody. And I think the media sort of taken hold of testosterone being the change and the thing that everybody needs, and I don't think it is for everybody, but in the right people, it is sometimes that added extra. And although it's just libido that it's licensed for, I very much do see that really can be people with brain fog that's just not going. It sometimes does just help clarify things. And I had somebody the other day say, I just feel more awake in the morning. I feel more motivated to do things. So I know in certain areas, because it's off license, you're not, as GPs, allowed to prescribe it, or it has to be recommended and initiated by a specialist, and then it can be taken over. I think it's amber in a lot of areas. So if it's initiated by a specialist and stabilised, it can then be taken over prescribing. It's a bit difficult where I work in the NHS. We can't prescribe, so we can recommend it. And again, that's sometimes enough by a specialist recommending it, but I think it's difficult. These patients sometimes get stuck in the middle a bit with tests.
Yeah, so we've got a couple of longer questions and one quick one. So we'll do Marina's first. Thanks, Dr. Nicholas. She's asked, would you recommend adjusting estrogen or progesterone in the first instance, assuming examination done, risk factors reviewed?
I think, to be honest, probably the progesterone. I think normally they're on that dose of estrogen because they need it from a symptom point of view. So if the symptoms are well controlled on the estrogen, I'd be loath to reduce that unless they'd not notice a huge amount of difference between going from one dose to the other dose of estrogen. So I normally probably would assume they're on that estrogen dose because they need to be, and do that and tweak the progesterone. There are some people though that have been on that dose for ages, and actually they don't need the estrogen. And actually those people, maybe I would start with the estrogen. I think there are other people that we go up on estrogen because we think we need to, and actually they don't notice much benefit on it. And again, if that's the case, I would go back down. But I would say more majority of cases, it's the progesterone that I would be tweaking.
Great, thank you. We've got a question from Jo as well. She asked, in your experience, is Ultragestand, I hope I'm pronouncing that right, better tolerated than patch progesterone for patients with progesterone intolerance?
So generally, I would say yes. So Ultragestand is a micronized progesterone, which is similar to our natural hormones, whereas in the patch, it's a progestin, which is more synthetic. So I generally would say yes, but I would say everybody's different. I think the other nice thing with the Ultragestand, obviously you can try it orally, but you've got that vaginal option as well. But to counter that, I do have occasional patients that just really don't get on with Ultragestand, and actually we do change to the patch, and even though it's synthetic, they get on with that much better. But I would say that's the minority. I think synthetic progestins are what people react to more normally.
That's a really great answer, thank you. And the last question that we'll take today, I think, just so everyone can get out on time, is from Ifeoluwa Gigi. She has asked, does testosterone provide bone protection?
It's a really good question. So estrogen mostly is what provides bone protection. In fact, it can be used as treatment for osteoporosis, estrogen. Testosterone, well, if you look at the metabolism of testosterone, testosterone does get broken down into estrogen as a metabolite. So I suppose there could be an element that it does have a bit of bone protection, if you think of it that way. But I wouldn't specifically be using it for that option. I mean, again, there's sort of muscle mass and that side of things with testosterone. But I would say it's majority the estrogen that provides the bone protection. Hope I'm right there.
That was really great in a nutshell answer. Yeah, thank you. Thank you, everybody, for giving up your lunch hours. This talk, obviously, was quite well attended compared with usual, so it just shows people are really keen to have this knowledge. If you've got any feedback, you can leave it in the chat. We're getting lots of thank yous. And just for everyone to note, we're not having a talk next month. It's August, so we're giving you a month off. But we'll be back in September with a talk from Tori Ferguson, who is a specialist accountant for GPs And we'll be sure to publicise that really clearly in the digest so that you can sign up well in advance.
Well, thank you very much.
Thanks for joining us. Thank you, Dr. Elphinstone.